this is an important gynecologic issue, prolapse, and we have a specialist here to talk about it. I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We brought a guest back she hasn't been with us for almost 2 years. People have been begging for her to come back. Dr. Carolyn Best.
It's probably something you said, Brad.
I think probably something you said.
All right.
Welcome back.
Thanks,
Thank you.
Dr. Best. Thank you so much for being here and helping us with this difficult topic.
And actually, a lot of people in the comments of your first video said, "Hey, what about prolapse? I think I have this, or what can I do about it?" So let's start at the beginning. So what actually is prolapse?
So prolapse is a term that we use about different parts of the body. It basically means things falling out of place, like almost like a herniation. So there's other parts as well, but in this context, we're talking about the pelvic organs. Okay. So it's the walls of the vagina or the pelvic organs descending or falling down towards the opening or even outside of the body.
Okay.
Thanks a lot, gravity. Jeez, wow.
Definitely. Yeah.
Okay. So this could be the rectum, the bladder, or the vagina itself can prolapse?
Right. So the pelvic floor is an important structure to think about in this way to help explain that. It's a diaphragm of muscle, like instead of being under our ribs, the diaphragm that we use to breathe, it's at the bottom of our pelvic cavity. It has a certain tone that's meant to help support and hold all these structures inside. And just like you mentioned, these different things, the urethra, the vagina, the rectum, and the bowel pass through there for various functions, right? So those are all the things that can be prolapsing in this situation, but we're mainly talking about them prolapsing through the vagina or through the vaginal opening.
Okay.
So it's the walls of the vagina that are descending or bulging down to create a sense of pressure as they come towards the opening or outside of the body, and that can incorporate the walls that have these other structures behind them.
Right.
Okay, and now if this is happening, what kind of symptoms will someone have if this is happening?
So the most common symptom is just the general sense of pressure. The nerves to this area are a little bit different than the nerves to the outside skin, like when we talk about incisions or things on the outside of our body, so it can be vague. But a general sense of pressure, like there's something sitting in the vagina or falling down or falling out, is the most common symptom that people might experience. To be honest with you, lots of women have prolapse, or people with female anatomy have prolapse, but don't have any symptoms at all. So that's important in terms of what we do about it, but it's important to say that lots of people walk around without symptoms, but if they have symptoms, it's pressure, discomfort, general discomfort, and it can start to impact functioning and quality of life, whether it's sexual function or bowel or bladder function. So those are all things they can experience.
When you say impact bowel or bladder, is it going to make you go more, go less, a little bit of everything, feel a sensation of urgency, incomplete emptying, whatever?
Yeah, great question. So it's a very common misconception that prolapse causes urinary incontinence. I think we talked about that in our last video.
Yes, we did.
Reference to that, but the point is that it doesn't directly cause incontinence, but it can create dysfunction primarily by increasing the sensation of needing to void just because of something being present in the area and it being irritating in that way. But you're right, it does create a general obstruction. Okay. So the urethra itself, especially if the front wall of the vagina is prolapsing, it has the bladder behind it. When it's prolapsing, it creates almost like a kinking effect of the urethra, which can impact emptying of the bladder. And then that can lead to also more symptoms of urgency and frequency. Right. So that's what it typically will do with the bladder. With bowel function, similarly, it can create sort of an obstructive symptom of difficulty passing stool. So it can impact function in that way. It doesn't usually directly cause incontinence of stool.
Okay. So if someone thinks they have this going on, they're going to go see their health professional. What's going to happen when you go see your doc about this, or your nurse practitioner or healthcare professional?
Well, thank you for bringing that up. I think the first thing is for someone to acknowledge to themselves that they're experiencing something, because this is an area, as we know, that can be embarrassing, or people can feel shame about even thinking about it.
Not anymore. It's on Talking with Docs.
Exactly.
That's right. That's what we do here. We break down walls.
So once you acknowledge you're experiencing something that may be related to this, definitely go see your healthcare provider. Talk about the symptoms and what you're experiencing. An examination will usually show whether it's prolapse that's present, because to be honest, there are other conditions that may create a similar sensation, or there may be a misconception, like I said, if they have incontinence or constipation or other symptoms, that it's because of prolapse when it isn't. Also, excellent practitioners in this area are pelvic floor physiotherapists. Right. So they actually are licensed to do pelvic exams as well, do assessments, even do some treatments, and get into some of the, non-surgical, non-medical, treatments there as well. They can also examine someone and tell them if they have prolapse.
So is it a speculum exam? Is that?
Not even necessarily. Like
a digital exam.
Even just examination, like looking visual from the beginning. Absolutely. If somebody has prolapse, especially if it's coming towards the opening of the vagina, you can see that just from looking on pelvic exam. But a speculum exam, like a speculum we use for a pap test, although that's not what we're talking about, can be used to more specifically examine and tell a patient what is prolapsing in terms of the different parts that can be prolapsing or to what degree.
Right.
Because we have different grading and staging systems of describing it in terms of what's actually happening. So that would be the most detailed way.
It's kind of a difficult part of the body to examine yourself. I mean, without a mirror or something, it's hard to see.
People do. I mean, you can look with a mirror. If you look with a mirror, you might see a pink bubble or a bulge coming down towards the opening of the vagina. So yeah, that would be a way that someone could examine themselves.
And if you saw the pink bubble, what are you seeing?
The wall of the vagina turning inside out.
Right, almost like a hot water bottle. Like turning in itself.
Yeah,
like
exactly. Okay.
Because you've seen a lot of hot water bottles turn themselves inside
no, but I'm
out.
trying to, for an
Or like
analogy
a
for
pink
someone.
balloon or something like that.
Okay, so it looks like a ball. Like
Yeah, it looks like a ball. It can really look like a ball coming towards the opening or something sitting there. And to be honest with you, if you don't know what that is or what it could be, that would be very scary.
Right, so you're seeing the vagina being pushed by the other structures rather than the other structures essentially showing up. They're not going to be in the vagina.
Exactly. And
without a hole.
Yeah, and that's a great point too, because many people will say, well, my bladder is prolapsing. What is that that's coming? It's not your bladder. It's the wall of the vagina that you're not used to seeing that's usually inside, looking like something that's coming out. But it's not the bladder itself. It's the wall of the vagina coming down.
Because the vagina is not perforated. I think that's maybe what people might not understand, right? So the vagina is still intact, so something's just pushing on the side of it rather than coming through a hole.
Exactly.
Yeah.
So the vagina, if you think about it in terms of it's actually a tubular structure that goes inside. And so it's that wall that is now bulging down from the pressure of the other organs behind it because it's lost its strength.
Yeah.
It's weaker, you could say, that's allowing things to come down like a hernia.
Excellent.
Okay, so you've got
Sorry, you're going to treatment, I know.
No, I'm not.
Oh, okay.
Sorry.
That's ready.
Just hold on and be. Get him a water bottle. Turn it inside out. That'll keep him busy for like 10 minutes.
He loves that analogy. Okay.
I'm saying, okay, so in addition to the visual exam that's going to happen when you go see a health professional, any other tests or any other sort of investigations that might happen?
Not necessarily. I think any investigations might be guided by other symptoms someone experiences. So there's other investigations for urinary incontinence, because as much as I said that urinary incontinence isn't directly caused by prolapse in almost all circumstances, someone might have it along with it. It can be associated because it has a similar cause sometimes. Right. So getting your urine checked, urinalysis and culture, an ultrasound or an exam to check how well you empty your bladder in terms of a post-void residual, we call it, might be helpful, especially if urinary symptoms are going along with the prolapse. But an examination will tell you have prolapse by an experienced healthcare provider.
What I was going to say is, who gets this? Why do people get this? Why does it happen?
So in this situation, anyone with female anatomy can get prolapse, but the biggest risk factor is having any pregnancies, especially any vaginal births. Right. So in the studies, it seems to be mostly associated with people with 2 or more vaginal births, but it can happen to anyone. I've certainly seen in practice the full spectrum of that. I've seen women with no pregnancies develop prolapse because some of the other risk factors might be chronic constipation, carrying extra weight, being overweight, having a life or a job that involves a lot of heavy lifting on a long-term basis, or there are some genetic or connective tissue diseases that predispose people to prolapse because the integrity of their tissues is weaker and they're more subject to the downward forces of gravity.
Like Ehlers-Danlos or something?
Absolutely. I mean,
really?
Ehlers-Danlos is one. To be clear, not everybody with Ehlers-Danlos would get prolapse.
Yeah.
It's actually a very uncommon cause of prolapse because prolapse is so incredibly common in general. The biggest risk factor is 2 or more vaginal births or any pregnancies.
Okay.
And gravity, you'll be out of a job if we colonize Mars, where gravity's about 1/3 of Earth, or the Moon, where it's 1/6 of Earth.
Well, sure, but it's not zero gravity.
So yeah, that's true.
Okay. So somewhere.
Right.
Yeah. And so it's essentially those muscles and the fascia that just get stretched almost like a trampoline that slowly just stretches and doesn't bounce back.
Yeah, like there's different levels of support structures. So there's muscles and ligaments that hold things inside, whether it's the cervix, the uterus, the walls of the vagina. We didn't talk about the uterus directly, but of course that can be part of what's prolapsing. Right. So those are structures from above that are trying to withstand those downward forces. And then the pelvic floor, like I said, is this diaphragm, has a tone that's trying to support from below. Right. So it's the breakdown or the inadequacy of those 2 structures that allows things to come down. With a vaginal birth, you're talking about inevitably some damage to those pelvic structures that may not show up over time, but with increasing age living against gravity for those years, it can eventually show up. But it can honestly happen at any age, at any stage after pregnancy or vaginal birth being the biggest risk factor.
Okay, what about the sequelae? Like, are there any problems that can happen with this? Secondary problems? Is it, you know, if you just leave it unchecked or untreated? Anything like increased urinary tract infections or anything like that that can sort of, other things that can happen as a result of this?
Eventually, yes, that can be the case. I think it's important to say that it's not dangerous, that if you have some prolapse, even if you're aware of it, because some people aren't, that it's not dangerous. You don't have to do anything about it to prevent these sequelae necessarily. If you don't have symptoms, it's okay to leave it alone, is the answer. But for eventually, things tend to get worse with time, especially if you're doing nothing. As you know, we can't get rid of gravity, right? So eventually it might start to lead to incomplete emptying of the bladder. That can indirectly start to increase the risk of urinary tract infection. Very rarely is it going to end up in something dangerous. I suppose in very rare cases, the prolapse can be out far enough and that obstruction can be severe enough that it can actually start to back up and affect the kidneys as well. I do not want people to worry about that. That's extremely rare. But generally, it's quality of life. So it will impact your quality of life, discomfort, sexual dysfunction, urinary changes, bowel changes, and just simply a sense of pressure that affects your desire or your ability to do your life, your physical activities. It depends what that means. Sports, exercise, their job, that kind of thing.
Okay, so can we go on to treatment? What are the treatment options?
What can we do?
So the first thing always is looking at your lifestyle and the risk factors that you might have that we can change, right? So if you're, you know, I don't want to say that weight loss is a direct treatment, but it can help if there's been a recent change in that status. What's really important is constipation as well. Looking at that, looking at the treatments for constipation, your diet, water intake, fiber, that kind of stuff, because constipation, if it's not a cause for someone, it's a risk factor and it can certainly make things worse and harder to deal with. In terms of the other treatment options we'll talk about. Pelvic floor muscle training or seeing a pelvic floor physiotherapist is a great option. These professionals will teach you to strengthen your pelvic floor, again, to try and help with those supports from below in terms of one of the elements of support. That can definitely, in my experience, reverse the objective findings of prolapse in its early stages. It may not make prolapse go back into the body permanently in a long-term way, but it's an excellent option that I think is important just for long-term results.
What's the success rate of that, just ballpark?
Well, I think that's really hard to answer, to be honest. I think it depends on the stage of the prolapse and the nature of the training you're doing. When we look at pelvic floor muscle training in general, we know that it needs to be done, exercises need to be done regularly and on an ongoing basis. So I would say, you know, when we look at studies looking at urinary incontinence, something different, if you do regular exercises for 6 weeks, about 60% of people will have improvement. We don't know the answer necessarily for prolapse directly, but it's important to address pelvic floor muscle strength because it may impact the other options as well.
All our viewers are rolling their eyes right now because we say exercise in just about every video we make, how important it is, or some form of physical therapy.
Well, it is.
Right?
Yeah.
There you heard it from someone who's smart, not just us.
With respect to the therapist, this is someone who's had special training, right? So you can't just go in, hey, I was hoping to get some pelvic floor exercise, and if the therapist goes, oh yeah, we can do that. I mean, you want them to be essentially advertising that they are registered or qualified.
You want them to be certified and trained.
Yes,
so there are there are physiotherapists that are specifically trained and certified in pelvic health and pelvic floor muscle training. So you want somebody like that, and they're licensed practitioners that are all over the place.
On a little side note, we don't have to dive deep into it. What about those devices that are like Eurospot and those types of devices that essentially saying this machine is going to do your exercises for you by sitting on some type of a device that stimulates your pelvic floor? Is there evidence that those work?
There is not strong scientific evidence that that's going to make a big difference, especially for prolapse or what we call higher order or greater extent of prolapse beyond the opening of the vagina out of the body. No. So I don't suggest it for that reason. I'm just being honest. It is, though, just a different modality of providing pelvic floor contractions, similar to exercises. So in that way, I think it's helpful under the umbrella of physiotherapy. It's a tool of physiotherapists, like other TENS or stimulation machines that cause involuntary muscle contraction that involves not having to either do it yourself for people that have difficulty identifying their pelvic floor muscles on their own, or who don't want to have a pelvic floor physiotherapist examine them or help them in that way.
Okay.
So it's a less invasive way of delivering the same thing.
It reminds you of those machines you could get to get the six-pack abs. Remember those ads? Yeah, you just put it on. It sort of, yeah, I don't think it actually worked.
Do you still use yours?
Well, I've given it a go. I'm on 7 years now, and there's no results.
So you got a 2-pack.
So in terms of next options
Yeah,
beyond
next options, that's what I
exercises,
said.
Okay.
a huge part of treatment for prolapse is something called a vaginal pessary. So
Yes.
a pessary is a support device. It's made out of medical grade rubber. It comes in a bunch of different shapes and sizes. And it requires a fitting by an experienced practitioner, but a pessary is basically something you wear in the vagina that holds things back up in place. It can be the only thing that we have that really can be instant relief if it works. It should be comfortable. It requires some maintenance and care, either by the person using it or from their doctor or nurse practitioner or health
You mean
provider.
like cleaning?
Yeah, cleaning
Okay.
and maintenance.
Yep.
But it can be a great short or long-term option
Right.
for improving quality of life from prolapse. I also believe, and there is some scientific evidence to show that it can help prevent the prolapse from getting worse over time.
That would make sense.
Again, because you're relieving the gravity, right?
Sure,
and the
yeah.
downward forces.
Yeah, and I kind of looked at this a little bit. So they range in price for like $50 to $200 kind of thing, and like you said, you get fitted. And then this is something you can either put in daily or maybe sometimes a couple of days, depending on the device.
Yeah.
And then regular cleaning. How does it stay there? I guess is what I don't totally understand.
Physics.
Okay.
And
I love physics.
yeah, I know. And the pelvic floor needs to have there are features of our body that make a pessary more or less likely to work.
Right.
The bottom line is that there are different categories of pessaries. Some will work by being in the vagina and occupying space. And by occupying space, they're preventing the surrounding structures from falling or collapsing into the vagina, which is what prolapse is.
Right.
But sitting above the pelvic floor and having some tone at the opening of the vagina helps because it'll help hold that in.
Got it.
Pessaries, when they get inserted, remember they're also, well, you wouldn't know, but they're folded, and so they're reduced in size, and when they go inside, they expand
It's like an
somewhat.
umbrella kind of.
Yeah.
Yeah, exactly. So they hold things in that way because they're expanded when they're inside, and that's how they hold things in.
Okay. Yeah, I thought that was very interesting.
All right. So we've got the physical therapy or
Yeah.
physiotherapy.
Yeah.
We've got the devices.
Yeah.
Next, treatment-wise, surgery.
Surgery.
Okay.
Yeah.
Can you tell us a little bit about that?
Yeah. So the surgery that we do on prolapse really depends on, first of all, the degree to which the condition is affecting someone's quality of life.
Right.
This is an elective surgery. It's not a life-saving surgery or cancer surgery. So it's a choice about how much the condition is affecting your quality of life. The goal of surgery is to restore anatomy and improve function and quality of life as a result. So the surgery depends on what's prolapsing.
Okay.
So part of our exam is looking for what's prolapsing so we could let someone know what surgery would involve. The vast majority of the surgery we do is minimally invasive, either done laparoscopically or most often actually through the vagina. So no abdominal incisions at all.
Wow.
And it's what we call site-specific, meaning that it repairs the compartment or the part of the prolapse that's coming down. And usually, almost always, there's more than one part prolapsing. So we're addressing them in combination.
Okay. All right.
An
So
overview.
then the success rate, surgery, ballpark. I guess it depends on what you're doing.
It depends on what you're doing, but to answer your question, we do know that overall there is a risk of recurrence of prolapse after surgery, because we're not going to be able to eliminate all the factors that we talked about that got us there in the first place.
Sure, fair.
I mean, in terms of pregnancy and childbirth, we usually encourage women not to have surgery for prolapse until they're finished their childbearing years,
Okay.
because a subsequent pregnancy
Yeah.
or delivery would almost certainly impact those results, right? Even
Yep.
if there was a cesarean section delivery, the pregnancy itself would affect that. So,
I think that's a good point. So,
Yeah.
so having a C-section is not necessarily going to prevent this, because I'm sure it seems
prolapse or recurrence?
like prolapse.
Right. I
Right?
mean,
It's the 9 months of carrying a baby that's part of it.
Yeah, it's the vaginal birth that
Yeah.
the biggest risk factor. So you change your risk factors, you change your likelihood.
Right.
But no, is it going to 100%
Right.
prevent that? No. I mean,
Got it.
being pregnant itself, and plus the other risk factors I mentioned, even for women that have had no pregnancies.
Right.
So coming back to your question, the recurrence of prolapse, we're never going to be able to eliminate all the downward forces or the risk factors,
Right.
even after surgery. So the overall risk of prolapse coming back in some way, shape, or form after a surgery objectively is somewhere between 20 and 30%.
Okay.
So that's high. And many people say to me, well, what's the point?
Yeah.
The point is that your quality of life is really affected and you 100% don't want to stay the way you are.
Right.
So if you're an optimist or you want to look at it on the flip side, it's a 70 to 80% chance you will be okay for the remainder of your days. And really, even if we have recurrent prolapse, all these same options that we've talked about treatment are still available to you.
So you're not burning any bridges.
You're not burning any bridges. Even, a repeat surgery if you need, the lifetime chance of having surgery for prolapse is upwards of nearly 20% for women by the time they're 80. And then a subset of those may go on to have another surgery, again, if the problem is affecting them to the degree to which they want to do that.
Is hysterectomy part of the algorithm?
Sometimes.
Yeah, so depending on what's...
It depends. The only time hysterectomy might be involved in prolapse surgery is if the uterus is part of what's prolapsing.
Okay.
We don't do a hysterectomy to prevent prolapse. In fact, having hysterectomy in your life may slightly increase your risk of developing prolapse later. I don't want everyone to think that because they've had a hysterectomy that they're going to get prolapse, but we know that when we look at everybody in the statistics. Right. But a hysterectomy is only done in combination with other parts of the prolapse surgery if the uterus is part of what's prolapsing. Okay. And what's really important to say is just doing the hysterectomy doesn't fix it. Right. We remove the uterus to allow us to do the remainder of the work, which is to suspend and reconstruct the vagina back inside. Okay. But it's also important to say, because my colleague and I did this surgery yesterday, is that you do not have to do a hysterectomy with a surgery for uterine prolapse. There are options where we can spare the uterus and suspend it back into the body using techniques of suspension to ligaments that are in the body.
Like tacking it, kind of.
Correct. To get it back into an anatomical position to improve someone's symptoms. Okay. Whether that's better or worse, we don't know, but there is some evidence to say that long-term results are similar. Okay. So then it depends on other factors in our life and in terms of, the risk factor of developing endometrial cancer or uterine cancer in one's life. Is this an organ that you still need? Right. Is it part of the prolapse? It becomes a conversation about preference and lifestyle.
Okay, so then, and with any surgery, there's always risks like heart attack, stroke, death, blood clot, infection, pneumonia, things that we talk about. Every surgical should be very, very low, but bad things can happen. We take precautions to minimize the chance of those bad things happening. Yeah. Just on the type of anesthetic, just out of curiosity, is it a general anesthetic? Is it a regional anesthetic? Is it a spinal anesthetic typically when you do these procedures?
It depends. So if we're doing the surgery laparoscopically, for whatever reason, it needs to be a general anesthetic. Okay. As you guys may know, with laparoscopic surgery, when we have to put CO2 gas in the abdomen, it requires a general anesthetic. Mm-hmm. If we're doing surgery through the vagina, which we almost always are, it can definitely be spinal anesthetic. So it depends on the duration of the surgery. A spinal anesthetic has a certain time and that it lasts. So it depends on the operating time expected. But we can definitely do a lot of prolapse surgery under spinal. The thing about a spinal or a regional anesthetic of that type is that it can delay our ability to get up and walk around and mobilize. Right. We call it after surgery. And the majority of the time, one of the benefits of doing the surgery through the vagina is that it's fast recovery, fast walking around, and oftentimes people can go home the same day. Right. So it might limit that, but to answer your question, either or we can do it.
Wow. That's a big conversation you have before your surgical procedures. Ours are a lot more straightforward. That's right.
It's a lot of talking.
Yeah.
It's a lot of talking. And about the risks and everything.
Yeah. Last question. Is any role for medications? Because someone's going to say, listen, maybe I'm not a candidate for surgery, or I'm worried about surgery. I've done the exercises and I've modified my lifestyle. Is there anything I can take that can help increase my tone, or is there anything that can address this? And my guess is probably not.
No. I would say my short answer is no. Yeah. Because like other conditions that you know about, this is a physical conditions, and so the treatments tend to be physical. Yeah. Yeah.
And on that note, we might save some people some money. Are there any supplements that you've seen advertised or anything that?
No, there is no science about any supplements that can directly have an impact on prolapse symptoms or treatment. In that realm, though, I will give a plug for general wellness and healthy diet. In terms of fiber, eating your fruits and vegetables, right? Yes, 100%. And keeping your fiber in, lots of plants in your diet to help with and prevent constipation, because that is a very real risk factor both for the development of prolapse and recurrent prolapse after surgery.
Chicken wings, do they play a role?
No chicken wings.
Not that we know of yet.
No chicken wings.
And actually, you have an Instagram channel. You're actually quite an accomplished cook, and you have your own channel.
I like to cook, is what I would say, Brad.
No. Your granola. My wife loves your granola. She makes the granola recipe.
Okay.
What's your channel called again?
my Instagram account.
Yeah, is it
Best
your
Budding
name?
Chef.
There you go.
Hey, can we put a link for that?
You definitely need to check this out because honestly, it's so good. There's lots of great recipes. Dr. Best is very modest, and she's gonna probably punch us when we're off camera. But you go check it out because it's really cool stuff. And now you know if you have any of these symptoms or you're wondering kind of what was going on, please go to your healthcare practitioner and have this conversation now. We've released you of the concern. Go and talk to someone. This is very, very common. They're going to be prepared to help you. And if you like this video, please like it, subscribe to our channel, and share it with someone that you think can help with this information.
And remember, you are in charge of your own health. Thank you so much. That
You're
was
welcome.
awesome. Appreciate it.
No problem.
We'll see you next time.